Good morning, everyone. First of all, I'd like to thank you for the invitation and this wonderful opportunity to be here with you today. My name is Francesca Greco, and I work as clinical psychologist in a sub-intensive geriatric department at Casa Sollievo della Sofferenza Hospital in San Giovanni Rotondo in Italy. Today, I'd like to talk to you about my research based on a structured teleround intervention in a sub-intensive geriatric unit for patients testing positive for COVID-19 and their relatives. The virtual round project consisted in a structured protocol which aims to provide psychological support for people who have tested positive for COVID-19 by a clinical psychologist. The idea of our work started in the December 2019 when the new coronavirus outbreak appeared in Wuhan, in China, and rapidly was spread in all of Europe. It's turned out that Italy was the first European country to suffer the severe effect of the virus diffusion, with a spiral of infection that placed this country at the top of international rankings, also overtaking China. The COVID-19 pandemic had a massive impact on the Italian healthcare systems, which became overwhelmed even before it was expected, leading to an increase of psychological pressure on ICU workers. From a psychological point of view, the COVID-19 pandemic had a negative effect on the mental health and psychological well-being, in particular of healthcare workers, for those who were in strict contact with COVID-19 patients in intensive care units. Now, let me bring your attention at that time.
Mio marito è morto, io ho la figlia piccola, come faccio a dirglielo e sto tossendo anch'io.
E mi è morta al telefono.
Questa epidemia ci ha portato via parecchie storie.
Vi ho visto cantare sui balconi, intonare l'inno nazionale, gridare che sarebbe andato tutto bene, mentre gli altri vi dicevano non fermiamoci, basta allarmismi.
Le risorse sono limitate.
Intanto le terapie intensive si riempivano.
E siamo praticamente pieni.
Questi suono dell'epidemia, come in guerra.
E poco dopo aprite tutto. Ma tanti erano aggrappati a un ventilatore polmonare.
È veramente una calamità.
Lo scenario che si configura è fondamentalmente questo, medicina delle catastrofi.
A morire da soli, con uno sconosciuto accanto.
Essere particolarmente drammatico per le persone che stanno morendo, perché proprio muoiono sole, insomma.
Insomma, vi hanno fatto vedere tutto.
Facciamo una sepoltura ogni mezz'ora.
Non sono numeri, sono mamme, nonni, papà, amici.
Le bare abbandonate.
Non abbiamo mai visto così tante bare depositate in chiesa.
Lo strazio di chi avrebbe voluto stringergli una mano. E se non fosse andato tutto bene?
Succedesse a voi, come vi sentireste?
From one side, this may lead to decrease of infection, but on the other hand, it leads to an increase of loneliness, anxiety, and depression. It is understandable at a time like this, people may be feeling afraid, worried, and or overwhelmed with the constantly alerts. All of this was higher for people who were in intensive unit care and their relatives too. In fact, all these patients reported many severe anxiety and depression symptoms due to the lack of communication and physical distances from their family. As you know, we are each born with a drive to seek social relationships. Our relationships give us an emotional support and encouragement in difficult times. Depriving people of social relationship can be physical and psychological devastating. So, the COVID-19 has changed the routine of patients, but also the medicine practice, leading some figures like psychologists to reevaluate a clinical operative method in order to help in a better way these people. But how to deal with this matter? And how help people in this clinical setting? Before introducing our work and so present our results, we need to take a little step back because I'd like to talk you about Mr. Alessandro, who enlightened me on this topic. One day, a new man was admitted at the COVID-19 unit. He was diagnosed with a COVID-19 pneumonia and severe symptoms were reported. Due to his clinical status, he was obviously isolated in the hospital. Despite the medical treatment, his clinical condition worsened. A mechanical respiratory ventilation support was then established. All medical staff was worried about his medical condition since the beginning. One day, Mr. Alessandro expressed his willing to see his wife and his family. So we decided to organize a video call with his family. Before the call, we managed an explanatory report about this patient's clinical condition and consequently a psychological support was arranged. After he saw his family, he started to cry. We thought he was devastated, but when we asked how he felt since he saw his family, he said, "Thank you. My family is what gives me the reason why I'm still alive." Since that day, Mr. Alessandro asked me to see his family every day and to start a psychological support pathway with him and his family. The medical condition of Mr. Alessandro incredibly improved since one day he was healed. Thanks to Mr. Alessandro, I had the opportunity to reflect upon his suffering deep under his clinical disease. The lesson I've learned was that a simple call without psychological assistance was not sufficient and maybe dangerous to manage the deep emotion that this clinical condition could bring. And it was in that moment that I decided to conduct this research. COVID-19 units coped with high complexity in providing care and integration among the care team and patient relatives. In fact, the COVID-19 patient, due to safety rules, may be prone to isolation and lack of communication with their family. In this clinical setting, virtual round has been successfully applied to cope with this task in the last 2000 years medical units. In addition, many other authors have demonstrated the evidence of telehealth for primary care and mental health services, supporting the effectiveness of telemental health through video conferences, telephone, or smartphone. Telemental health is practical, feasible, and appropriate for the support of patients and family members during this pandemic, but a simple call without structured psychological support was not sufficient and maybe could be dangerous. It could be dangerous to manage the deep emotion induced by the SARS-CoV-2 infection in intensive care unit. To date, previous studies have shown that telepresence provides clinicians with the ability to monitor patients as well as to communicate with all members of the healthcare staff. But few research have studied the role of video assistance intervention in intensive care unit with COVID-19 patients. So, the aim of our study was to evaluate the effect of the structured virtual round protocol in a setting of an intensive unit care, geriatric COVID-19, on anxiety and mood state for the patient and their relatives. This study was conducted from the 3rd February 2021 to the 3rd April at the Intensive Care Unit COVID-19 department. All the patients were admitted to the geriatric COVID-19 unit from the 1st February to the 3rd April, and all the subjects were studied. Our inclusion criteria were the following: no severe cognitive impairment, no sensorial deficits, and informed consent to participate in the study. 75% of the patients met the inclusion criteria. All the subjects who were found to be eligible for the study underwent a virtual round standard protocol of care. The virtual round protocol of care consisted in a video call with a tablet device conducted by a psychologist that established cooperative communication between the healthcare staff, nurses or medical doctor, and their relatives at the bedside of the patients. The virtual round consisted also in a video call with the patient relatives, in which it was clearly explained the standard care and the role of each healthcare member. Anxiety and depression levels were assessed for the patient at the baseline and after the end of the protocol by the Hospital Anxiety and Depression Scale, also known as HADS. Patients' relatives were investigated for depression at baseline and after the end of the protocol by the Beck Depression Inventory Primary Care. The Hospital Anxiety and Depression Scale is a self-assessment scale and is found to be a reliable instrument for detecting states of depression and anxiety. The anxiety and depressive subscale are also valid measures of severity for the emotional disorder. The questionnaire comprises 7 questions, 7 for anxiety and 7 questions for depression, and it takes 2 to 5 minutes to be completed. For both scales, score less than 7 indicates no cases, a range from 8 to 10 miles, and the range from 11-14 a moderate disease and 15 to 21 a severe disease. On the other hand, the Beck Depression Inventory for Primary Care has 7 items, with each item rated on a 4-point scale. It is scored by summing ratings for each item. Items are symptoms of sadness, pessimism, pace failure, and loss of pleasure. From a psychological point of view, the object of intervention was to offer a basic psychological support to people who have tested positive for COVID-19. Such compassionate talking or counseling entails specific components of psychological listening without judgmentally, giving reassurance on general information and encouraging self-help and other support strategies. More specifically, the psychological intervention was aimed to promote feeling of hope about recovery, express happiness and be in contact with the emotion of the patients, encourage family support, encourage expression of relief after sharing worries or anxiety, and think on coping strategies. It has to be noted that one of the most reported coping strategies was the faith in God. Let's spend a little bit time on statistical analysis, and we conducted a descriptive statistics analysis were used to describe the patient characteristics. Continuous variables were expressed as mean values plus minus standard deviation, and we use JMP software by SAS for the statistical analysis. All the patients admitted to the geriatric COVID-19 unit were studied. The study carried out from the 3rd February to 13 April 2021, a total of 49 patients hospitalized for COVID-19. It was obviously that the main complication was pneumonia COVID-19, and the present study included 49 patients, mean age of 79, and with one relative for each patient. The average mean of the hospitalization for each patient was 16 days, and the mean virtual round duration was about 16 minutes. Here you can find some results. We show virtual round show a significant decrease in both anxiety and also in depression for patients, and there was a significance and also there was a reduction in depression for relatives of these patients. In conclusion, virtual round has reduced anxiety and depression in patients hospitalized in a subintensive COVID-19 unit. And it has also been found to be ineffective in decreasing depression in the relatives of these patients. Our data confirm the efficacy of virtual round in the subintensive care settings. This evidence supports the key role of multidisciplinary team, focuses on the importance of social and psychological support during the hospital stay. However, the study has some possible limitation, considering it was a small size sample and it was a monocentric study. For this reason, more studies will be consequently necessary to better validate the importance of virtual round as a standard care tool in intensive subintensive care units for the elderly patients. From this experience, the lesson I learned is that preventing isolation when you are sick is a very powerful tool. It's a powerful tool to heal the patient. Thank you for your attention.